Very good evening to all of you. On behalf of Relisys Medical Device Limited, I want to welcome you all in today's evening and a heartfelt thanks to all our faculty and audience who have taken out their valuable time from their busy schedule. Before we commence to our today's agenda, let me take this opportunity to take you through the journey of Relisys. With the inspired vision of Dr. Abdul Kalam to make medical care affordable, the company became an independent entity under the name of Relisys Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market high quality medical devices in cardiovascular range at most affordable price, thus helping needy patients in India and across the globe. Backed by technocrat and medical specialists, the name Relisys emerged from reliable system, which ensure performance, efficacy, and safety to the patient. The strategic path adopted by the company was to use innovation and cutting-edge technology besides scale of production to achieve product and pricing advantage over competition. Today, we own clean and green state-of-the-art facility built in more than 12 acres of land, 160,000 square feet build-up area, clean room of more than 60,000 square feet of 10K, HVAC building management system, built as per US FDA norms. Entire facility is certified as ISO 13485, DSR approved R&D laboratory, fully integrated end-to-end solution for manufacturing stent and catheter. And today we are very proud to announce that we are one of the largest stent manufacturer in the world. This is a small glance of our factory. With the vision of expansion in 2018, Relisys has acquired Multimedics LLP, a C-mark company, as a part of expansion plan. This is our vast product range. We do have a drug-eluting stent Premier breast stent, bare metal stent Cobalt C, balloon catheter Pearl SCNC, angiographic diagnostic catheter Anand, C-mark disc Ensure Ace, guiding catheter Amber, guide extension catheter Access Guide, sizing catheter Quartz, pulmonary artery catheter Ripacath, transcatheter heart valve, trig valve transcatheter, aortic valve Vienna, expansion, that is an expandable introducer sheath, Relica, the microcatheter. We do have a peripheral vascular product range as well. The Coral peripheral diagnostic catheter, Advert B drug-coated PTA balloon catheter, Engross, that is a PTA balloon catheter, Engross HP high pressure PTA balloon catheter, Perinity bare metal peripheral stent system, Peripac Ace sirolimus eluting peripheral stent system. This is our new product launch. We recently have launched Matrix IVL, that is a coronary intravascular lithotripsy, abdominal aortic stent graft system, Metagraft AAA, thoracic stent graft system, Metagraft TAA, cutting balloon Pearl CB, coronary drug-coated balloon Pearl DCB. And soon we are going to launch central venous catheter, hemodialysis catheter, covered stent, transcatheter valve, transcatheter pulmonary valve, transcatheter mitral valve, endoventral valve, and CTO recanalization device. And today we are very proud to announce we are present in more than 70 countries across the globe. With the introduction of Matrix IVL, we are expanding our focus from innovation to education that empowers the outcome. With this, let me welcome you all to today's Crack Card Code, the Modern PCI, a webinar series where we will witness the evidence-based discussion on integrated crack card code strategy that transforming the outcome of coronary intervention. Let me take this opportunity to welcome the facilitator of this evening, Dr. Pranay Alinjan sir. He is a consultant interventional cardiologist from Ramakrishna Care Hospital, Raipur. He is a proctor for multiple procedures like root ablation, optical coherence tomography, intravascular ultrasound, intravascular lithotripsy, left bundle pacing, and he has several publications and presented in national and international forum. We welcome you, Dr. Pranay Alinjan, and thank you once again for your valuable time. I would like to hand over the session to you, sir, now. Kindly take this forward. Thank you, sir.
So, good evening, everyone. So, our chairperson for today's meeting is Dr. Vijay Trehan sir. Sir needs no introduction. He is master of master, teacher of teachers. And from early days, we are learning from his excellent complication sessions. So where he is presenting all the complications and we are learning from that. We have saved many lives from complications because of that only. And sir is currently chairperson of the Maharaja Agrasen Hospital, Delhi, and he was director and HOD of the cardiology at GB Pant Hospital, New Delhi. So our first speaker for the current program is uh, Dr. Kushal Pujara. He is a senior interventional cardiologist at Sri Krishna Hospital, Anand, and he will be presenting about critical eccentric nodular calcium with Matrix IVL. Over to you, Dr. Kushal.
Can you hear me now?
Yeah, you are audible.
Okay. So just can you see my slide now?
Yeah, they are visible.
Can you see my share the screen? Can you see my slide?
Yeah, slides are visible.
Okay, it's fine. So good evening, everyone, and thank you for giving this opportunity today for this academic session where we're going to discuss about management of calcium. Calcium is the enemy of the human cardiologist as well as the patient. So it's very important for us to know the different intervention tool to manage the calcium in coronary arteries. And today we'll discuss about the interesting case of the eccentric nodular calcium. Just going back to straight to the case. So basically, I work in the University Hospital in Karamsad, Gujarat, and this case was around 2 months ago, 3 months ago. A 77 years old male patient who has diabetic for the last 30 years, hypertension, and who has on and off chest pain for the last 15 days, exertional dyspnea. And then he this time admission was suggesting of an STMI, troponin was positive 8.6, our normal value 0.01. ECG history of ischemia in the lateral lead. So mainly in the infralateral leads, you can see ST depression. So if we go into background of this patient had anterior LMI 2004, and he had PCI to LAD performed in USA. The all family stays abroad, and then he had repeat angiogram for 2009. In January 2025, he came us with the short of breath, so I did angiogram. That time also he had triple vessel disease. However, EF was around 25%. So we decided to go for the cardiac MRI that time, and cardiac MRI shows that the ILD is almost non-viable. However, we proceed for the angiogram, and angiogram was showing the dominant circumflex artery, and then it was nodular calcium that time as well. So the patient decided conservative management because of age and frailty. So they did not decide. I spoke to the many family members, but they're not ready in 2025. But this time it's a classical NSTMI, and then the patient was very unwell with the symptomatic. So we just decided to for re-angio again. And this time also EF was 20%. EFR, and then you can show is elevated is akinesis, and severe hypokinesia, basal inferior wall, grade 2 MR, and the creatine was around, on admission was around 1.5, and which is back to again 1.3, and after 2 days of medical management. Is diabetic, LDL is well controlled, is 34 LDL, BMI is 23.7. So it's not much risk factors, well controlled diabetes, well targeted LDL, BMI is in the again target range. Still he had this issue. So this is directly go to the angiogram here. You can see this angiogram here, and this patient had very tight LCX, around 99% critical calcium in the dominant circumflex artery. Right coronary artery was non-dominant, and it was also again 90% disease, but small non-dominant. And you can see the LED stent, which was implanted in 2004 in the US, which also shows critical stenosis. However, we confirmed in last time this part was not viable. So this time we focused mainly on the circumflex infralateral territory as per the ECG changes. So just stopping at this here, these are further two images you can see here. So should we just interactive discussion now, or should I go present and then we can discuss further? We can discuss the plan here before I show them my next slides.
I think there is a thick nodular chunk of calcium looking at the angiogram. So
Yeah.
definitely it looks like a nodular calcium only. So you have to either go for one rotablation or orbital followed by lithotripsy, whatever your liking is.
Yeah. So I agree, it was a very tough calcium. You can see here, right? So first of all, it was we can see calcium, but the limitation of angiogram is we cannot feel the calcium. So unless we pass the balloon, let's pass the wire and then pass the balloon, then only we can see what the consistency of calcium. I think all calcium management, that is very important. Okay, whether how hard is the calcium. So again, spoke to family, discussed the depth on the table, because you can see here the circumflex dominant artery, EF is very low, and the LAD is non-viable, again, which is severe ISR. So essentially, patient was living in this dominant circumflex artery calcified. So depth of the table consent was taken. Again, not for CABG, obviously for the patient choice and their age as well. So the son-in-law is a cardiac surgeon in the UK, and then he moved to New Zealand. So I discussed with him everything as well, related to whatever we percutaneous PCI. So I passed. This was the different steps. We'll go one by one. So here these are the what I have used in the next few steps. So first I tried to fill the calcium. So I passed the wire, put 2 wires, and there's some ostial circumflex as well, signaling distal left. So first 2 wires in the LAD and then LCX, and then just try the 2x12 SC balloon, and you can see clear cut. There is a dumbbell shape. Balloon did not expand properly. Of course, there was no question at this point. The imaging catheter won't go at all, and everyone agrees with that because it's very tight calcium. So many times our guidelines says, oh, do imaging first and then decide how thickness of that, what do you do is the IVL, you do is rotablation or the orbital. So imaging is a no way you can go in this patient imaging. So that's why that limits our further decision maker. But 2.5 balloon, you can see dumbbell shape here as well. So, and after that, I tried to, this was the after 2.5 balloon high pressure. And you can see chunk is there. So calcium chunk is there. So I tried to pass IVS after 2.5. And then you can see, as usual, IVS could not cross beyond this calcium nodular. So I was stuck there. Now what to do? Because IVS is not going. So what to be done further? So after 2.5 balloon, IVS could not go, and you can see the calcium is there. Whatever IVS was able to pass, I can see this calcium is there from at the tip of this nodular. And then decide to go with the again 3x12 NC balloon. Always there is risk of perforation, risk of dissection is always there. But I just tried to do the 3.12 NC balloon. And rotablation, it was good choice here, but I was trying to avoid because of if the circumflex got no flow then you stuck. So in that case, patient can collapse on table. So it's a one single artery patient was living with that. So I was trying to avoid the rotablation. We dilated the 3x12 NC balloon here. And then after 3, I was able to pass the IVS, and I can see there is the quite thick nodular calcium you can see on between the 12 to 5 o'clock position. And then after that, we decided to go to after 3 NC balloons, they decided to go straight to the 3.5 IVL balloon. So this is a 3.5 IVL balloon, 120 pulse. We are going around 40-60 pulse with the the proximal LCX, and then around some pulses are left for the LMS to LCX balloon as well. So this was done around 100 pulse, and then I kept the 20 pulse reserve in case I require LAD. So I used the 100 pulse, and then I said, let's wait for the in case I require to LAD. So LAD I did not focus anyway, priority. So this was 2.5 NC balloon, and this was the post IVL Matrix IVL. So you can see quite significantly the luminal gain was quite significant after this 3.5 IVL balloon. I used afterwards 3.25 cutting balloon as well from the Relicis, and then I used around 4 millimeter NC balloon as well post IVL. So post IVL, I used the cutting balloon 3.25 and then 4 mm NC balloon, and this was the picture after that. So this is IVS again after this proper dilation. You can see the IVS is crossing very smoothly here after this IVL balloon. So IVS was not crossing before IVL, but after crossing IVL, I was able to cross the IVS very well. You can see the crack in the calcium as well in the post Matrix IVL in the IVS run. So next, I focus on I opened the LCX, so flow is there. So the sensitivity was very high. So each time I inflate the balloon, patient blood pressure is dropping during the table. So it went up to around 50-60 blood pressure every time I inflate the balloon circumflex artery. So it was very sensitive area. I had to be very careful during this procedure. And then once LCX was enough luminal gain, I focused on the LAD that time. and I did the NC balloon and then cutting balloon 3.25 balloon, and there was reasonable flow in the LED, and then I put the 3.5 dab in the LED. I did not put on the stand. There was no point because the LED area was not viable. This was just for proximal LED. You can get some supply. So, and then I just took the stand, which is 3.5 by 32 millimeter drug loading stand, starting from the left main to the LCX, possibly covering the whole nodule. We can see this inflated very properly. So many times when you do angiogram, this is we had the IVUS anyway, but angiographically also we can see in the two different direction whether the stand is inflated properly here or not. And you can see stand is inflated properly. So we was happy that at least stand did not have any dumbbell shaped inflation. And then after that, we went to 4.5 balloon throughout the circumflex, throughout the stand. And left main, we did the pot with the 5 balloon, 5 balloon. And this was the final pictures. What we can see in the IVUS run has also done post this 4.5 and 5 NC balloon. And we can see calcium is still there behind the stand, sir. Unfortunately, we don't have the high definition IVUS. We don't have OCT or lab. So, but we can see there is a calcium stand is luminal diameter was around 10 millimeter circumflex. We are very happy with that. The calcium, we did not drill the calcium here. So calcium is behind the stand, sir. So always we can see some stand as well, but how the luminal area was good. This was the final result we got after that. And his last 3 months patient is symptom free, is doing very well. And the heart failure symptoms also resolved, and the patient is symptom free for last 2-3 months. So again, this was the final slide. This was pre, and this was the post result. And this result, IVL result, was quite satisfactory. And we can see the IVL is a blessing for the this such a patient. Even in nodular, initially when IVL came, we always focus concentric calcium. But now we have your nodular calcium like this. Also, you can use IVL successfully, and you can get good result. So everyone should aware about the calcium debugate tool, when to use orbital, when to use rotablation. And this IVL is a less minimum complication, more efficacy, especially if the balloon should cross the lesion. That's only we have the condition for this patient. Thank you.
So nice presentation, Dr. Kushal. So I will agree on 2 points. First thing, any patient who is having a single surviving artery, like this patient, LED is non-viable and left dominant system, or a single surviving vein graft, rotablation or orbital should be the last choice you should take. So rightly you have not taken the rotablation or orbital atherectomy, because any slow flow in the single surviving artery will there will the collapse of the patient was there. Secondly, why you have taken a 3.5 stent? Because clearly it was 4O vessel, more than 4O vessel.
Yeah, so we didn't have any shelf, and this was the synergy stent. So we have synergy stent 4, we are not available, but 3.5, I want to take 4, but we know 3.5 can go to 5. So that's why we selected 3.5 and then posted with the 4.5 and 5 balloon.
Okay, but nice final result.
It's a synergy stand. So I was knowing that his expansion limit is quite high. We didn't have 4 long stands. That's why I had to take 3.5 and then post that with the 4.5 and 5 NC balloon.
So nice final result and nice take on doing a drug-coated balloon in a territory which was non-viable. Otherwise, putting a stent would not. I agree. They have gone, either ISR would have again developed, or the patient might have developed stent thrombosis because of non-viability. So thank you.
Cutting balloon and the NC balloon, cutting balloon, and the drug loading balloon in the LED territory.
So what pressure usually you go with the cutting balloons?
Cutting balloon up to 12, but in this case we went up to 14 as well. So I know that after 12 is a burst pressure for that, but usually I inflate myself all the balloons. I don't give any my assistant, because of then only how much pressure to execute, rather than. So I went 14 millimeter on this patient.
So usually what I do, I go till 16, 18, 20 atmospheres with cutting balloon. If you are taking, if the vessel size is 3.5, you can take a 2.5 cutting balloon, and you can go till 12, it will become 2.75. 16, it will not go beyond 2.8 or 2.9. So usually the chances of perforation, I have not seen any perforation with cutting balloon till now. So
I agree with you.
Because they mentioned not go beyond 12, but usual practice I go till 16, 18, 20 also. And I have seen many senior operators also going till that high pressures with cutting balloon.
So I think the only thing I agree with you, when the balloon size is smaller than the diameter of vessel, then we can go higher. But only I was worried if it balloon perforated, then the once balloon perforated, then that jet of dye, once it's like jet of like contrast, that can cause dissection. So there's always I keep in mind, but I can understand, I agree with your view that, we can go higher in the larger vessel as well. Yeah.
So thank you. So our next presenter is Dr. Naveen Chandra GS. He is an HOD of cardiology and lead consultant in the Department of Cardiology at Esther Whitefield Hospital, Bangalore. So welcome, sir.
Yeah, hi. So I'll share my
Yeah, you can start, sir.
one minute.
So Trehan sir has joined, sir. Good evening. Sir, you are driving a car, I think. So you can continue to be on mute. Sir, you are on mute.
The presentation can be seen, Allah?
No, I know I'm on mute because I'm stuck up with my Digiyatra. I'm trying to do that. I'm listening to it.
Okay, sir. Okay, sir. So
My,
shall we start the second case, sir?
Yes, yes, please.
Yeah, okay. Thank you, sir.
My screen is visible, no?
Yeah, it's visible, sir.
Yeah. Thank you. Thank you for this opportunity. And my case is calcified ISR, IVL, which was used for a bailout procedure. This is the case, a 69-year-old male who presented with history of on and off angina and a rest angina for last few days. Normal LV function, he had a mild SC changes in the inferior leads. Drop was elevated, so we took him. But with the previous history, he had a systemic hypertension and a history of a PCI to RCA in 2011. Immediately after first angioplasty, he had another ACS, probably a stent thrombosis or something. So they had put two overlapping stent in the mid to distal RCA. And he had an ISR in 2025. A DCB was done to RCA in 2025, just few months before this intervention. So he also presented with an ISR for that. I didn't have the CD of that to review the CD, but of course I got the CD after I did the angioplasty because he came in an NSTEMI, so I had to do it. And then I reviewed the CD to get some light. Why did this DCB fail? I have not shared the left system. Left system is okay. The right system, the proximal LED had some mild plaque, mid LED to distal LED, whatever stent was there, there was a critical a narrowing of the stent almost from the mid of the to the distal segment of the stent. It was critically narrowed and there was a good flow was established, but there was a critical narrowing. Probably this is the cause of the NSTEMI and this was the culprit lesion. We advised an angioplasty for it and we went ahead with an angioplasty. This was the first angioplasty. We started with a 2.52 millimeter balloon, 2.5 millimeter balloon, and even after 2.5 millimeter balloon, we could see a dog boning effect in the mid part of the stent. There was hardly any opening in the mid part of the stent, and we in multiple almost a New York cutting balloon 2.5 was taken and a 3 millimeter balloon was taken. We could not get it. Then of course, initially, then we did an IVAS to look for what has happened. We can see that there is a distal stent which was there. Sorry, I will run it. Distal stent. There is a distal stent which was very well opened. There are some neoantimal hyperplasia there in the middle of the stent. There's some neoantimal hyperplasia again. Now, this is the part of the stent. You can see that. Sorry. You can see that there is a severe narrowing and you could see a neoantimal calcium actually. So inside the stent with the neoantimal hyperplasia, there was it was not a stent. Initially, we thought it was an underexpanded stent. It is not an underexpanded stent. There was a neoantimal calcium which was there. And this calcium was extending almost up to the mid of the proximal part of the stent. And this was a proximal RCA. So there was a very significant concentric calcium, calcified arc was there in the neointima in the middle of the stent. That's the reason it was we were not able to open the stent. At this point of time, options were to go ahead with the DCB here because we could not open it anywhere. That could have been a bad choice. As we all know, for a DCB to work, we need to have at least less than 30% of the lumen, less than 30% residual lesion. We need to have a good, I think the DCB, most of your work is done by lesion preparation itself. The success of the DCB can only be defined by a lesion preparation, not by just by delivery of the drug. And here the lesion preparation was totally inadequate, and I reviewed the CD, and the old CD, there was definitely the same amount of constriction was there, and they went ahead and did the DCB. I think that is the reason why the DCB had failed in them. Second option was to go for a high pressure balloon. Again, risky because high pressure balloon, there was a severe dog boning. We could open the calcium, and probably there is a, because the cutting didn't open, there's a risk that we could have some rupture there. Another option was a rotablatant. Yes, it would have been an attractive option because there is a concentric calcium was there. But again, there were two layers of stents, although there was a neointima there. But again, a rotablation, we were a little reserved about doing a rotablation there because we could achieve some amount of already almost 2 millimeter opening of the vessel was achieved. So I don't know how much of a rotablation would have worked. Orbital, again, because of the stent was there, again a contraindication to ablate this way, and it could increase the risk of the procedure itself. Then we thought, because it's a superficial calcium, thick plate calcium, we thought we would go ahead with an IVL and see if it works. So then we took a 3 millimeter Matrix IVL. We went ahead, 80 pulses we took. You can see in this clearly there was the constriction opened up in the third or fourth attempt, and we could get a good, there was no hardly any constriction was left. This was after the IVL. Angiographically it looked good, and even in the IVUS, if you can see, there was a this is the distal stent. You could see there is a good opening of the distal stent, and neointimal hyperplasia, of course, was there. And this was after the IVL again. And we could see that there was a lot of cracks in the calcium. You could see 2-3 cracks in the calcium was there. There was a good lumen gain. There was a good opening of the lesion was also seen in this individual. Now, this is an IVUS image. And this was a post-cutting balloon. There was a area of almost a 4.8 millimeter square, and this is post IVL in the same area. You could see a clear cut calcium cracks, 2 to 3 areas of calcium crack in the area was 9.34 millimeter square. Almost we achieved almost a double the lumen gain, and also cracks of the calcium are also seen. This is very important for DCB until you see some good cracks in the calcium, because otherwise a drug delivery is going to be inadequate. And lumen gain, a good lumen gain, and less than 30% of the 30% less than 30% residual fusion is important to be seen. This point of time, we were confident that we could go ahead with DCB. Following it, 3 into 30 millimeter paclitaxel DCB was done. 6 atmosphere for 60 seconds we had kept, and for an optimal drug delivery to achieve a stent-free strategy. And we could, even in the DCB, we could see a uniform expansion of the balloon, unlike when we did the first. Before this also, after the IVL, again, we did a 3 millimeter cutting and a 3 millimeter NC balloon high pressure dilatation was also done. Post DCB, this is a lesion. This is the result. You can see a good expansion. There was in the mid RCA here. There was some amount of dissection which was seen, but it is an old dissection actually. It is basically a calcium plaque there. So we had confirmed with the IVUS there was no problem. So we deferred from putting any more stents there. A good luminal gain, no this one, and telemetric flow was established in him. Now, learning points. ISR is an extremely complex phenomenon which needs more comprehensive assessment. And knowing the mechanism of ISR is very important to treat. Imaging gives a lot of perspective. Achieving a luminal gain is an extremely important thing. And calcified neointima is seen in around 5 to 10% of the patient, poses a unique challenge before the stenting, and achieving a good result here is an extremely important thing. Cutting balloon and IVL in selected patients gives you an excellent result. Thank you. I'm very happy to take any of the comments are there.
Nicely demonstrated, sir. So rightly said, any ISR can have neoatherosclerosis, which can be fibrotic neoatherosclerosis or a calcific neoatherosclerosis, or you can have neointimal hyperplasia.
Correct.
So whenever an old stent is there, more than 1 year or 2 years old, most likely it is calcific neotherosclerosis. So as per the guidelines now, they recommend that if calcific neotherosclerosis are there, you should implant a stent. But if you have a good lumen area, as you have shown a lumen area of more than 9.3, so drug-coated balloon again in an old age individual is definitely a good option.
And also the problem was there are 2 layers of stents already in subsequent individuals. So I didn't want to put another layer there. That's the reason I refrained from putting it. As you said, I even thought about it in between. Because of the 2 layer of stents, I thought we would just give one chance at least.
So you have shown a good image on IVAS. If you permit me, can I show an OCT image of just a small case of
Absolutely.
OCT image
Wonderful.
showing a new
I'll be happy to. Yeah,
Yeah,
absolutely.
so just 1 second. I'm taking some time from the other two operators. Sorry for that. Okay. So 1 second. So are my slides visible?
Yes, yes.
So just a small case, an 80-year-old female. She had undergone angioplasty to LAD and RC in 2021, diabetic and dyslipidemic. Again presented with effort angina of 1 month. So this was a tight ISR. So looking just at the small focal ISR, tight instant restenosis is there. Nothing, no calcium is visible, nothing is there. So, but on old age, 4 years later presented to me. So again, I did the OCT. And if you can see this OCT, thick chunk of calciums are there. You can see thick chunk here, 5 mm. Here you can see 5 mm. This is the point. And the lumen area of only 2.6. So just going on ballooning this calcific neoatherosclerosis, you will not have any lumen gain. So thick chunk, both the side, here also and here also, and both are 5 mm. So the length is only 5 to 6 mm, but it was more than 500 microns on the both side. So this I went again with a high pressure balloon dilatation. Usually my go is at least 16 atmosphere cutting balloon. I got the lumen area of 3.91. So very low according to me. Again, I went into 3 into 10 OPNNC at 36 atmosphere. Now I got the lumen area of 6.15. Again, post pre-dilated with 3.5 into 20 mm essential pro. And this was the lumen area which I got. So most of the area is 8, 7, 8, 6.5. So OCT areas are slightly lesser than the IVAS areas, but still more than 6.5 in the area. And this was the final result, and this was the lumen areas. So though guideline recommends calcific neoatherosclerosis, you should stent, but as sir has documented, we can definitely go again and do a drug-coated balloon if we get a good lumen area of more than 6 in the, if we are getting in right coronary arteries, I think more than enough.
Wonderful
So,
case.
thank you, sir. So next speaker, 1 second. So our next speaker is Dr. Sanjeev Patra, sir. So sir is Director Interventional Cardiologist at Desun Hospital, Kolkata. Sir will be presenting on optimizing lesion preparation, the foundation of successful PCI. Over to you, sir.
Okay, am I audible?
Yeah, you are audible, sir.
Okay, my case is not so complex, simple. I'm just presenting because this is the first time I use that Matrix IVL. So just to show that we are not behind the Western technology, and I used it. I used both the releases stent and their IVL. In a patient is around 70 years old, 78 years, had an ACS non-STEMI. I had a previous inferior LMI, inferior posterolateral, EF around 35%, and this underwent a PTCA to LCS in 2022. Prior to that, she was implanted as pacemaker 2021. So again, he admitted with the non-STEMI MI drop around 4 to 5. So we did the angiogram. Angiogram has a long segment accent calcific LED, and L6 stent was patent. RCA territory was there as around 60-70% lesion. Also, that territory was akinetic, so we didn't consider that area, that artery to. So when you looked at the LED, you can saw that is a dense calcium burden present. So we decided to go for. We thought about doing rota, and then we thought, why not doing this new IVL from Relicis, the Matrix IVL? Let's see the result. So just that with that concept, I wanted to know that efficacy and how does it compare to the Western counterpart. So unfortunately, the slides are not made by me. My junior, they didn't upload that moving image of the IVL. So the IVAS was done before. So IVAS was one area is a concentric almost 360-degree calcium, and it's a relatively longer segment long segment calcified lesion. So we went ahead. We went through femoral axis, and initially we did the cutting with the 3 or initially there's a 2.5 SC balloon. Then we put that cutting 3.10. Then we did the NC non-compliant 3.15 around 18 to 20 atmosphere. Then we went to go it with the IVL 3x12, delivered around 70 pulses at the calcified site. So post IVL, I don't know that didn't upload that IVS images. Post IVL, we saw the breakages in that concentric ring of the calcium. So I put a 3x44 Relicis stent. And I post-dilated with that 3.512 with the proximal part and 3 interdistal part. And so this is the final result I got with our Indian made stent and Indian IVL. So this is my first use of Matrix IVL. So I was quite happy. Post procedure IVAS was not my fellow didn't put that. So I saw it was the calcium obviously behind the stent, but it's adequate luminary area, no dissection, nothing, and it's no problem in passing the stent or all the stuff. So the balloon made it very simple. This lady who is a tuberculosis, 78 years, frail. So I did the procedure very quickly. So my point is that probably this IVL, this is a low-cost IVL compared to the Western counterpart, and can be used in more patients, particularly with the LV dysfunctions and with possibility of no reflow, much more in high calcium loads, deep calcium. So I was quite happy with this balloon, and just to show that my experience with my first Matrix IVL. So I want you to comment about regarding you probably used more than me. So I just wanted your opinion, your how does it compare to the Western counterpart, like Shockwave?
So wonderful result, sir. I think that it is very much comparable to the counterpart, and the results you have shown has already shown that the IVL is working very well. The stent was very well expanded. There was no under expansion anywhere, and it was well flowing stent. The best thing with the Relicis stent are the ISR and stent thrombosis are very less. So I have been using it for last 10
Yeah.
and be less ISR and stent thrombosis with this stent. Other Indian companies I have seen some having ISR and all, but with the Relicis stents, you can be dead sure that the patient will be doing well for 10-15 years. So past 10 years, I have been using Relicis stent and I have not seen any ISR till now.
people are little apprehensive. My colleagues, okay, Indian made things. They are coming with the rota ablations, and then Indian state. There's some apprehension of some of the colleagues. So when we are doing this process with these states, they find that we are not behind the Western counterpart. Okay, I understand in some areas probably some states are maybe better than us, but in general, for the routine procedure, we can jolly well do it our Indian manufactured product.
So Trehan sir is again available. Sir, your experience with Matrix IVL and where you will like to use IVL other than cutting balloon or rotablation, sir. Sir, you are on mute.
So if you ask me, as far as IVL device is concerned, I'll say that it's a real magic device. Absolutely no doubt about it. However, there are two constraints, according to me. One is that everybody knows that this is costly and it does work only for a short distance. The balloon is about 1 centimeter, 12 millimeters. And even if you have so-called 120 pulses, but they may not be sufficient in some of the cases with diffuse, multiple, and heavily calcified areas. We have seen that it goes there and you deliver all those pulses and you are able to do something, but not really up to the mark. Nevertheless, it's a device which is reasonably safe. The other problem, according to me, is the deliverability. Many of the reasons you are not able to take this. It's a device, not a balloon. So you have to kind of make some way there. Either you'll have to predilate that area in case it can be done with some balloon, or you might have to create a way by some kind of atherectomy, and might even need some additional extensions of the guiding catheter to take it there. I'll say other than this, I'll say that I'm sure coming time this device is going, because the ease with which it can be done, used vis-a-vis atherectomy, the issues related to atherectomy in the form of especially slow flow. Perforation they do take place even with this because it weakens the wall, but the slow flow part is definitely much less with these IVL balloons. So I will say that in situations where you are handling a vessel which is a single surviving artery, and somebody wants to do rotational atherectomy or orbital atherectomy or any other thing, I think the risk of then I think the problem is great. So I'll say it's a very handy device which has come. It still needs improvement, and like you are going to come with Javelin, where you are going to have forward delivery of this thing, so that your delivery is not through a balloon. It is going to be through the tip of a catheter, so that in calcified areas where you need a rota to be done first, you may take your IVL, this Javelin catheter without rota also. So it's, since it gives a forward delivery of the shock waves. And I'm sure in the coming time, two things, the deliverability is going to improve. A balloonless technology where only catheter will be able to deliver shock wave, and a sleeker model. I'm sure, because if I go back 35, 40 years ago, no stent was deliverable. It used to be hell of a task to deliver a stent. I'm sure they are going to be miniaturized and you will be able to deliver it through catheters which are going to be much less bulkier than this. And also the number of the pulses. It's only a gimmick by the company. I don't know whether what is there with the Relicis. If you take a catheter and this catheter gives you 120 pulses, then it stops to give pulses because of the console. You change the console, you change the catheter to the other console, it doesn't recognize that it has done something. So it will give you another 120 pulses. So they have just made it so that we don't use and reuse the same catheter elsewhere. But I'm sure in the coming time, with more and more competition, that part is going to go off. And if the delivery of the catheter is easier, if the cost is less, and if you're able to deliver more number of pulses, I think it will be a kind of way to go for calcified lesions. And some of the super calcified lesions where even this catheter is not advancing might still attract rotational atherectomy, or some of specialty situations where even orbital may be required. But I think large number of cases will be addressed by IVL, even if as much.
Sir, you are not audible.
I was not audible all throughout, or was
No,
not
all
audible
throughout you
just
are
now?
audible. Last 30 seconds that.
So what I'm saying is, if these points are being taken care of, which I'm sure the company is going to take care of these points, that they are going to be miniaturized, and the competition is going to decrease the cost. See, the bare metal stents of this J&J variety PS 1530, that was 1992. The cost used to be 87,000 rupees. So many years ago, the cost was 87,000 rupees. If you had deposited that much money in Kalp Bricks, Kisan Vikas Patra, or any other bank, this would have sold to 50 lakh rupees. So today, those tents, which was for 87,000 rupees, if somebody wants to sell it to you for 8,700 rupees, nobody will buy. They were such lousy stents. But I'm sure as the technology is improving, I'm sure the technology is also going to improve here. And this is going to be very handy. And calcium is not going to go away. Calcium is going to be a big, say, problem for the interventionist. And if you have a simple solution for at least large number of calcified lesions where you can deliver this catheter, especially if the cost is not very high, I'm sure a large number of the operators will not even try to learn rotational thread, especially if you don't want to do very difficult cases.
So it is always so pleasant to listen to you, sir. Such a lucid orator, sir, you are. And the analytical skills you have, I have never listened to an operator doing such an research work like things. So you are saying that there should be a catheter which should deliver the pulses from front. So you should not be having a rotablation use or anything. So such a thinking, sir.
I'm
Realizes I
sure in the coming
hearing.
time,
So realizes people must be hearing, sir.
in the coming time, you are going to have it.
Yes, sir.
In the coming time, you are going to have it. This
Yeah.
business of 2.5 millimeter size, 4 millimeter size, that is going to go off. You are going to deliver through a simple catheter, and through a simple catheter as small as a micro catheter. Wherever a micro catheter goes, you will be able to deliver these IVLs. All what it does, it tries to make the vessel wall supple. If the vessel wall is supple, you don't need to dilate the vessel and make it so beautiful that you hand it beautiful or a fashion parade. You want to dilate a vessel that a lesion with physiological or hemodynamic significance, that is taken care of. And I'm sure a large number of lesions will be just taken care of by a simple balloon technology. A balloon technology is going to be a far simpler way to handle calcified lesions than an atherectomy. Atherectomy still, I think, any day is going to be a cumbersome process. It is going to have its own issues. You see, you're doing a left main, you don't want to lose a bar. You have a balloon, you have a IVL balloon, let a bar be in circumflex, do an IVL from LM to LAD, do an IVL from LM to L6, still have a bar in the other branches. So maybe with L6 or an LAD D1, so you can retain a bar, which is unlikely. If there is a dissection, you can still use an IVL. You cannot use those atherectomies. If there is a thrombus, you can use an IVL. You cannot. If there is a chance of having a slow flow, you can use an IVL. So IVL usage is going to be, I think, much easier. There is a bend, acute bend. You can use an IVL. You cannot use orbital, or you can use rotation atherectomy. So I will say the range of IVL is going to be far more, provided they look at it. They look at the cost. They look at the deliverability, and they also look at the newer ways of delivery. I'm sure that is going to expand the usage of lithotripsy itself, not balloon related lithotripsy, but lithotripsy in the coronary arteries. Wherever there is a litho, you will like to do tripsy.
Okay, sir. So shall I ask for next speaker, sir?
Please.
Yeah. So our next speaker is Dr. Chandra Prakash Thakur. He is consultant cardiologist at Apollo Hospital, Guwahati. He will be presenting for plaque modification in calcified LED stenosis. Over to you, Dr. Chandra Prakash.
Good evening, sir. Sir, am I audible?
Yeah, good evening. You're audible. Slides are visible.
Sir, am I audible, sir?
Yeah, you are audible.
Okay, okay. Uh, Good evening, everyone. So, after listening to all the legends about IVL, my case will be very short and brief. It is all day-to-day care case, basically about use of cutting balloon for the plaque modification. So, my patient is a 73-year-old female who presented with chest pain and diagnosed to have NSTEMI. She has comorbidities of hypertension, diabetes, hypothyroidism with creatinine of 1.7. And when we took the patient was uh, having a tight lesion in the LAD. That was the target vessel. That was from proximal to mid. There was 90% focal stenosis. So what I want to show is that when we took the patient, this is a lesion, uh, which we can see that there was a calcium, and this was a very focal uh, stenosis. So we started with the NC balloon. We took it, but after that, even using the NC balloon, there was no as such dilatation we could see. Then we took the pearl cutting balloon 2.5 by 10, and with this high precision cutting balloon without this tearing of the tissue, we
You are
were able to crack this up. Can we see this after this use of cutting balloon? And this vessel preparation, when I think it is not playing. When we took the NC, it was not dilated, but after the use of cutting balloon, it acted as a proper surgical cut, and there was, we can see in this video that there was dilatation in this lesion, and that made this case very easy. And basically, when we use the cutting balloon, there is a active element, like there is a proper carbon alloy stainless steel which directly attached to the balloon, and it helps in the very long, neat, and longitudinal incision, and that reduces the radial force and prevents the uncontrolled dissection also. Uh, so after that, we took the stent in the distal one, and after that, we put one proximal stent, and there was a symmetrical expansion achieved. And this was possible only because of this. And after that, we could done the stent optimization, and post-stent dilatation was done. So this was the final outcome. So I think this is very basic case which all of us are doing in day-to-day practice, but this significantly like helps us, like how a cutting balloon is very handy in the plaque modification because of its very precise cutting technology. And we all know that cutting balloon helps basically in fibrocalcific lesions. And because of these rigid metal blades which anchors the balloon, it securely eliminates the risk of slippage also. That is the watermelon seeding effect. And there is a proper stent expansion. And it has a very safety profile also. And we can see that there is a very little perforation and dissection which we can see. Thank you, sir.
nice final result. So rightly use of cutting balloon helped you out, and you got the
Yeah, this is very basic. Yes, sir.
no calcified case is a basic case. Whenever you are doing a calcific lesion, it's never a basic case. So that is the, I will never say a calcium modifying tool, if you are using it, is a basic case.
Okay.
So whenever you are using a cutting balloon or IVL, rotablation, orbital, it is always a specialized case. Simple operators are not doing that, and doing it properly and getting a good result, I think, is definitely commendable. So I think no rotablation case is presented. Can I present one rotablation case? Trehan sir?
Yes, please.
Yeah, so one second. Can you stop sharing?
Yeah, just Yes.
So I will be presenting a case of rotablation in ostial left main. So whenever we are dealing with an ostial left main or ostial lesion specifically, so most important thing is always the guide catheter stability, because if you are not having a stable guide catheter, if you are deep throating it, you can dissect the vessel. If you are not properly aligned, you can cause perforation or the aortic dissection can be there. Burr can get engaged or jump, or you can damage the ostium or the aorta. So whenever we are using an ostial rotablation, always small size burrs are very well. You can use either 1.25 or 1.5. Though some operators says for ostial lesion, if you are not able to pass, 1.75 can be used, but usually I prefer 1.5 mm burr as my day-to-day thing. So the guide, most likely you should not be having a guide which is having extra backup support like EBU or XB. You can, for ostial lesion, JL is very good. You can just coaxial floating, you can keep the guide or partially disengage. Always have a rotablation speed of 140 or 180. My usual go-to speed is around 180,000 RPM. And if you can do imaging, that is the best thing. So a 68-year male, non-diabetic, non-hypertensive, no addiction. Chronic stable angina of 3 months duration, echo ECG bang normal, but TMT was done, which was positive. So I am not keeping the angiogram, just starting with the plasty. Right side artery, again, diffusely calcific disease, which I am planning after 3 months. So though you can see in this angiogram in aleocaudal, the left main looks normal, but I was not able to engage this thing. So just partially aligning, which I have already said, I have to wire from outside. So just partially aligning the JL guide, I am wiring from outside, and now you can see what we are dealing with. So a tight calcific osteoproximal left main, proximal tight lesion is there, and proximal LAD also is having tight lesion. Mid LAD is also having a tight calcific lesion. So this you cannot do with EBU, because EBU will definitely go and hit the ostium. It is not possible to do rotablation while, because some part if get dissected, it is not possible to do rotablation from there. So you have to just partially disengage. Coaxial alignment should be there, otherwise the burr will jump and perforation can happen. And this I just, after aligning the catheter, started with 1.5, started with 180,000 RPM. So usually some operators believe 140 or 150. I usually start with 180,000 RPM. If I am not able to cross, I go to 2 lakhs RPM. So though some slow flow can occur because of this, and you can see in the second run when this, 1 second. So this is after the rotablation. Some opening of the ostium of the left main is there. Mid LAD again is opened up, but there is no flow phenomena is there. So wired LCX decided for provisional stenting, though ostial LCX is having lesion, but I was not in favor of doing a bifurcation stenting. This may differ. Some will say DK crush would have been better option in this case, or some will say tap could have been done. So again, 2 into 10 semi-compliant at high pressure, 2.5 into 10 mm cutting balloon at 20 atmosphere for 20 seconds. So after that, 2.5 into 48 mm DS at 10 atmosphere in the lower part of this thing. So some slow flow after stent implantation was there. Again, an ostial left main positioning 3 into 38 mm DS was done. And this was after proximal stent deployment. So distal part of the stent, if you can see, there is some spasm is there in the LAD. So ostial LCX pinching was clear, which was I again expecting 4 into 10 mm patency. I did at very high pressure. Ostial part again I flared up with 24 atmosphere. That post proximal optimization, clearly ostial circumflex is pinched. So my earlier plan again was to do a drug coated balloon to the ostial, which I have not done earlier. Was after this I had just crossed, pre-dilated again with 2.5, 3 into 20 mm drug coated balloon. and kissing balloon done with 3 into 10 mm patency with the same drug coated balloon during that 60-second inflation. So after this, so usually whenever I am doing a drug coated balloon to a larger size vessel, not a smaller caliber or small branches, I always keep the balloon and take the shoot, because once you are doing a drug coated balloon at the larger size artery, flap will always be there and you will not be having a proper opening of the artery. So now with this balloon kept, I can clearly see the ostium of the circumflex is well opened, and no need to do a stenting at that point. So the final result, so the distal spasm which was there has gone now after NTG. Ostium of the left main is well opened and the struts are there. Ostial circumflex because of flap is looking like pinched, but I have already demonstrated in this also. Again, one second. So in this view, you can clearly see flap is there. But now you can see the ostium of the circumflex is very well opened. There is one flap is there. This patient is doing fine. This I have done, I think, on 5th August. Now it is today is 22. So 20 days there is no closure of the vessel. Patient is walking 4 kilometers daily, doing well. Second case again, post CABG patient, I will say. Ostium of the circumflex. For this speed is slightly faster for the angiography. Sorry.
Let us discuss this first case first.
Okay, sir.
So it will be important to discuss. Why I'm saying is there are a couple of things which some people might think differently. One is that you have used a 3 millimeter stent for this LM. We don't have any good imaging.
Yes, sir.
And a 3 millimeter stent for the left main likely to be under. Even if you blow it with a 4 millimeter balloon, it is likely to be under. And I feel that most of the time the left main size is 4 or 4 plus, and taking a 3.5 millimeter stent gives you more number of, say, bigger hoops and more delivery of the drug than a 3 millimeter stent. If you try to blow up a 3 millimeter stent and go up with a 4 or 4.5 millimeter balloon, so there are two things. One is the drug delivery is going to be less, and second thing is the hoop strength is going to be different if you try to overdilate. So else, because we do not have good imaging in this case, so I'll say that in the absence of good imaging, if let's say imaging is telling you that the LM size is 3.5, then of course we'll say 3 millimeter stent, which will be okay for a distal artery also because you're using a long stent. So 3 millimeter stent may be okay for a 3.5 LM. But the kind of vessel which we are seeing, my gut feeling is that this left main would have been definitely much bigger than 3.5.
So I made
And you've already
4.3
taken a
with
4
24
millimeter balloon.
atmosphere, sir. So
So if we are taking a 3 millimeter stent to 4.3, the hoop strength will be an issue. The drug delivery is also going to be less. Rather than this, if you use a 3.5 stent, I think all those things are going to be better. The only thing is it may not be that conducive
so only issue was the
for a distal vessel. So
part
you
of the
deploy
artery.
these stents at lower pressures and you keep working within the stent tip. Doesn't matter. You can deploy these stents at low pressures and work within the stent till near the end of the distal end of the stent. If you have imaging is very good, but if you don't have imaging, then maybe distally you can be 275 for the same 3.5 stent. You can lock the hinge points maybe a couple of millimeter proximal to the distal end. And if there is a vessel which is not terribly calcified at the distal end of the stent, then you can always very easily inflate it with a little bigger balloon at nominal pressures. So my thinking is that maybe 3.5 would have been a better choice. Okay. Now the whole game about LM ostial stenting is guiding. According to me, the whole game is guiding. Some people may not agree with a 1.5 bar, which may be much smaller for a left main. Let's say left main on imaging is 5.5 or 6 millimeter, then 1.5 bar, which is okay for rest of the coronary tree, may not be okay for a LMOS. But much more important than the size of this bar, because this LMOS is the only place where if you change the trajectory of the guiding catheter, you can use a smaller bar, you can still shave larger area of the atheroma. by pulling a guiding catheter, pushing a guiding catheter, clock or a counter clock on the guiding catheter, sometime pulling and pushing the wire, sometime having a 1.5 burr can do much better and a bigger cutting at the os. And sometime because the wire, proximal part of the wire, once you are coming from aorta to the coronary artery, is in a relatively free space. So if your speed of rotation is decreased, then your wire tends to wobble. If the wire is wobbling, then the area of ablation will be bigger. So we can use the same bar and you can decrease the speed with some wobbling of the wire in the aorta and increase more ablation. You can change the trajectory of the guiding catheter. You can also change the trajectory of the wire in the LED, diagonal or circumflex. And hence you can ablate much more with a 1.5 bar than you would have done in the absence of these maneuvers. But it is still, still in some cases, it is possible that on imaging the vessel size is much bigger. Say if the vessel size is 5.5 or 6, then I'll say that I'm not saying that 1.5 bar is useless, but this is a place where one can think of a bar size bigger than 1.5, could be 1.75 or even 2. And I, in my practice, have used even bigger than 2 mm balloons for LM osteum. But those burrs are not nowadays not available. They're not available in India. It is very difficult to ask for them. They are not on shelves. But the whole game, according to me, for LM osteal rotational atherectomy is a guide. Your guide, first of all, has to hook. And many times you're trying to find the os and you have a guide which is large enough. Generally, it is 7 French. So you're trying to fish around and find the LMOS and you injure the LMOS. So this, if you injure the LMOS, then I think upfront you have created a problem. So which will be very difficult. So a simple solution for this situation is, which when we did our first left main some 30 years ago, the plan was that we'll take a 4 French diagnostic from Termo. We'll take that 4 French diagnostic and hook the left main artery with a 4 French diagnostic and have a wire ready. So the same thing can be done here. You have a wire ready with a 2 boss attached and have a this rota wire ready to hook the left main with a 4 French Termo, which is a very light and gentle. If the ostium is tight, it doesn't do wedging. Even if it does wedging, it is doing only for a short time. Then you quickly pass a rota wire, let the wire go deep in, and just pull out this 4 French diagnostic from Termo. And after this, then you can take a bigger catheter over this wire, and that bigger catheter can be supported by a support 3.5 wire, which goes along with the catheter. So this is how you can bring a 7 French or sometime even a 8 French catheter close to the LMOS without injuring it. And you can keep that bigger wire, which is taken there to deliver the 8 French guiding, to deliver even your rotational atherectomy burr. And of course, once you start burring, then your this protection wire, which is a supple wire or a float wire, has to get back. And in case you have a guiding catheter too far off from the os, then to avoid injury to the LMOS, this is a situation where you can have a float wire and you can float the wire. If the float wire is getting out of the guiding catheter and into the sinus, and your rota burr along with the sheath is getting past the tip of the guiding catheter, so you can ablate the LMOS without injuring the LMOS with the guiding catheter, and yet your wire support is there on the sinus, which can keep your guiding catheter relatively stable. So I think with these small little changes, you can do it. And sometimes if you do not want to do all these juggleries, then for a short time burring, you can have a, because you know that for all practical purposes, the moment you get close to the left main, you're going to jeopardize the flow to the left main. So this is the only situation where you can cut a hole or two in the guiding catheter, which can help you just at the time when you're trying to take your burr. Let's say your burr is there at the LMOS and it is not ablating, and you want to increase the guide support. And that guide support you want to increase for maybe 10 seconds or 5 seconds. So during that time, if you have a guiding catheter with a side hole, that side hole will permit some flow during that time when your guide is touching the LMOS. However, the disadvantage of the side hold is sometimes it gives you a false sense of well-being. But here, since you're doing a left man, you know what you're doing. So it is not like a guide which you keep intubated and you're working and the pressures are being recorded proximally, which are wrong. So this is, I will say, a special situation where you can have a hole or two, which will help you only during the time when your burr is not going and you want to advance your guiding and give support for your burr, because the burr, if your burr is, let's say your guiding catheter is in the ascending aorta, now you want to take the bar over the bar, it is possible the bar doesn't go because it needs a backup support. So for the backup support, if your guiding catheter doesn't have a hole, during the time when you're giving a backup support, you will be throttling the os. So if you have a hole or two, then for that short time of 5-10 seconds, you can kind of take your guiding close to the os with some hole on the side. Little bit of flow will be allowed. You can burr past, pull out the guiding catheter as your burr gets beyond the os. And I think that way you can do it. But still, I will say, and the LM hostile rotational atherectomy is a challenge. One more important thing than this is that you should ensure that your guiding catheter is coaxial. You have to ensure it, because if it is not coaxial, then as your burr is advancing out of the guiding catheter, if the trajectory of the wire is not the same as the trajectory of the wire as it enters in the left main, then this burr can cut through. Your wire can be cut, because this is a place where your wire is entering from free aorta into the coronary. So coaxiality has to be of great importance, and that generally you check the coaxiality in two orthogonal views. And I'll say both iliocranial and ariocaudal. These are the views which should be done uh, before you want to advance your burr. So these are my comments about left main ostial rotational atherectomy.
Achha, sir, second thing, what about use of drug-coated balloon in circumflex ostia?
I think rather than not doing anything, it is better to deliver some drug there. For sure, I think it was a decent result at the circ ostium, and I will refrain from putting a stent there in this situation because this was a decent result. Even if some dissection is seen, it was a nice brisk flow in the circumflex. So even if some dissection is there, so see, the stents are not there for all dissection which you see. Let's say you're seeing dissection on OCT. OCT guys might keep telling you a dissection of this degree, this length, and then getting into medium
So
is all
any
right.
media involvement,
But
sir, more than 2/3 arc
so,
involvement
so
and all
they
this.
will they will say I'll say that is not non-scientific, but at the same time, since you're not having an OCT, and we also see the behavior of the calcium of the dissection is more related to the flow. So I will say that there was a trial by the name of music trial some 35 years ago where people after dissection were kept in the cath lab with a wire out for half an hour. And those dissections which did not compromise the flow in half an hour, they are unlikely to compromise the flow after that, provided your pressure head is not high. If you don't let the blood pressure go high, then even if some dissection was there, that dissection which was seen but was not compromising the flow is unlikely to compromise the flow if it has not compromised the flow for half an hour with the bar out. Nowadays, half an hour is a luxury. It is very difficult to have a patient on table for half an hour with a wire out. But if you don't keep it for half an hour, just many times, just short time, even 5-7 minutes will tell you what way the wind is going to blow. And if you find the flow is brisk, then no matter what kind of dissection it is looking, I think because see, if it is a dissection of the shaft where you do not have a branch elsewhere, I will say that if you have a dissection, even if it is not flow limiting, it is looking bad, just stent it. But if you have a dissection as a side branch of a stent, which is far more important, and if you then stent the side branch in the form of whatever, whichever, whether you do a T or a tap or whatever, you do a QLO after you have stented, these are the provisional techniques which you will use. So they are all complex, and they add to the metal, they add to destruction of the first stent which was already deployed from LM to LED. So I think one should try and balance out all those things. And say I'll give an example. Let us say this is an elderly gentleman where there is some issue about DAPT. This is 80 plus kind of a patient, and RCA is there and is flowing well. This situation is different from, let us say, there is a young person who doesn't have a bleeding issue. He has a left is dominant, and then you have a dissection there, and he's likely to tolerate diabetes much better. Then I think my inclination will be a little more towards giving a much better hemodynamic result and stent that area and work, do a little more work there. But I think you'll have to individualize, and I think in the field of interventional cardiology, it is very important to tailor according to the need of the patient. Just because we can do one kind of a stenting and we have done 2000 cases, that doesn't mean this is 2001 case, do it. I'll say that again, try to tailor it for the need of that patient, and I'm okay with this. And if you finish it with the coated balloon, I'll say it is icing on the cake.
So take home message is tailor. Each patient is different. With how much experience we have to take a proper tailor-made suit for each and every patient, and we should treat patient accordingly. So
That is what
nice.
I feel.
So I think nice cases were presented. Thank you all the presenters. It's already 9:45, sir. I think we should stop now.
I'm just about to reach the airport.
Okay, sir. Thank you, sir. Thank you, sir,
Thank
for
you so much.
participating.
Yeah.
Okay, sir. Good
Thank
night.
you for having this session. It's
Good
very
night
nice
to all of
session.
you.
Thank you, sir.
Dr. Pranay, I will just take 1 minute to, on behalf of Relisys Medical Device Limited, I want to extend our sincere thanks to all our faculty, especially our chairperson of this evening, Dr. Vijay Trehan sir, our facilitator, Dr. Pranay Jensen, and all our speaker, Dr. Chandra Prakash, Dr. Kushal Pujara, Dr. Sanjeev Patra, and Dr. Naveen. Thank you very much, sir, for all your time, your valuable time which you have given for this webinar. We hope this webinar could able to bring a meaningful and insightful discussion on the table, and we will continue to do this academic webinar series, and our next program will be in the next month itself, and we will soon announce the date. With this, let me conclude the session here, and once again, thank you, good night, and happy weekend. Thank you, sir.
Thank you all. Good night.